Assalamu alaikum. I will present my lecture today, the venous thromboembolism. What is the combination deep vein thrombosis and pulmonary embolism? Let me introduce myself. I'm Dr. Ahmed Osmane, professor, assistant professor of vascular surgery in surgical department at Alexandria University. Let's start. As introduction, we know that up to 2 million people in the United States suffer from deep vein thrombosis every year, and 600,000 experience pulmonary embolism, which is a fatal. Okay, it is a fatal. Pulmonary embolism is fatal, killing more people than AIDS and breast cancer. What are the risk factors leading to venous thromboembolism, pulmonary embolism, and deep vein thrombosis? Immobilization, bedridden, bed recumbency, or surgery within the last 3 months, stroke leading the patient to bedridden, malignancy, age by itself, surgery requiring more than 30 minutes or half an hour of anesthesia, it is alone recumbency, chronic heart disease, or respiratory illness. All these are predictors or risk factors for pulmonary embolism and deep vein thrombosis. Again, to some extent, traveling in a plane for long sitting, superficial vein thrombosis, or catheterization, inducing catheter inside the vein, obesity, hypertension, pregnancy, all these are risk factors. The pathology of these risk factors is through the Virchow triad or Virchow triad, which is a triad of venous stasis, endothelial injury, and hypercoagulable states. For example, the advancing age, immobilization, anesthesia, stroke, hyperviscosity is a venous stasis, leading to venous stasis, stasis leading to clotting, occlusion. The endothelial injury, for example, by surgery, deep vein thrombosis, history of deep vein thrombosis, venous access, trauma, all these leading to endothelial injury, and this will again lead to thrombosis. And the hypercoagulable state is the hyperviscosity of the blood itself. Sure, it leads to occlusion, and this could be affected by cancer, estrogen, family history, heparin-induced thrombocytopenia, or by thrombophilic diseases like the protein C and S, or deficiency, active protein C, hyperthrombocytopenia, and antiphospholipid antibodies prothrombin 2210 mutation. All these are the hypercoagulable states. So we have to assess this venous thromboembolism by Wells criteria. It is a clinical. Is this patient who is at risk to gain the venous thromboembolism or not? So this criteria is given scores. More than 6 is at high risk, from 2 to 6 is moderate risk, and 2 or less than 2 is low risk to affected by venous thromboembolism. For example, clinical signs and symptoms of DVT is they are present. It will get 3 according to the calf tenderness, swelling, erythema, whatever. If there is a history or presence of pulmonary embolism, it will get a higher score. Tachycardia will get a score. Immobilization, surgery, diagnosis, history of diagnosis, hemoptysis, manifestation of pulmonary embolism, malignancy, or all this will take a grade, and according to this will be at high, moderate, or low risk. This is the Wells criteria. Manifestations. Let's know that more than 50% are asymptomatic. So in the clinical sheet, when you search for a deep vein thrombosis, you cannot judge the patient didn't pass by a history of or experience of deep vein thrombosis, except by duplex. So you write in your sheet, no history of deep vein thrombosis could be detected, I don't know, till investigating the patient. Because of more than 50% are asymptomatic. What are about the symptoms? Might be pain, edema, just erythema and warmth of the lower limb, and if there is associated thrombophlebitis, I can feel the cord-like, tender and red vein, occluded thrombosis vein, superficial, and although the Homan sign is well known, it is by pain, by dorsiflexion of the foot due to calf muscles touching the thrombosed subsoleal plexus, It is only present in 30% of the cases only. How to differentiate between venous thromboembolism and others, edema, causes of edema and leg pain? For example, infection causes edema and leg pain. Trauma, injury, venous insufficiency, chronic venous insufficiency is not a case of acute deep venous thrombosis or acute venous thromboembolism or pulmonary embolism. So how to reach the diagnosis? Deep venous thrombosis, if we have the leg symptoms and clinical suspicious for DVT, we can determine the pretest probability of DVT by, if the patient has low probability, I have to some extent, so I have to first start by D-dimer test. If it is negative, خلاص, okay, DVT is excluded totally, but with low probability. But with low probability and D-dimer is positive or not available, I have to pass to the next step, which is venous ultrasound. By venous ultrasound, if it is positive, so confirm DVT. But if it is low probability and there is negative and no DVT or negative D-dimer, so DVT could be excluded. So D-dimer is very sensitive to DVT, but with duplex ultrasound. In condition when I have high probability of DVT, I have direct toward the gold standard test, which is the venous ultrasound starting. If it is positive, DVT is confirmed and no other test could be needed. But if it is negative and I have still high probability of the deep vein thrombosis, I have to confirm by D-dimer. If it is positive, it might be, because D-dimer is elevated in several conditions. So it is still suspected. I have to follow up by venous ultrasound again. But if the venous ultrasound is negative and the D-dimer is negative, it is cut down that there is no DVT. It is a simple logarithm. Investigation, how to detect by tools. The ultrasound, as I said, it is the gold standard. D-dimers, contrast venogram, MRI, and spiral CT. The ultrasound in the proximal vein sensitivity is 97%. However, in the caudal veins, sensitivity is only 73%, and it cannot distinguish between an old clot and a new clot. D-dimer is a degradation product of across-linked fibrin blood clots. However, instead of it is a degradation product, it could be elevated in recent major surgery, hemorrhage, trauma, pregnancy, or cancer. So it is not pathognomonic, but its positivity, together with proved ultrasound, it is accurate for deep vein thrombosis. So it is sensitive but not specific. The value is in the negative test result. Because if I am doubt and I cannot judge and the duplex is not conclusive, when it is negative, it is good positive, there is no deep vein thrombosis. The contrast venogram, sorry for this gold standard, it is not the gold standard for imaging. The gold standard is the duplex. However, we can image entire lower extremity sensitive in asymptomatic patients. Our limitation is that it is invasive and we use a contrast and radiation again. The magnetic resonance, it is a good test for suspected iliac veins or inferior vena cava. It is usually used for that reason. And it is more sensitive than any other non-invasive. However, its expense and lack of general availability has a limit use. The computed tomography spiral we can use for the chest to suspect pulmonary embolism, either plain or with contrast, which is more specific to show the pulmonary artery arteriogram or angiogram. Pulmonary artery angiography, it is used to confirm the pulmonary embolism. 50% more costly, more than, and there is a risk again for contrast and radiation. This is an example of the color duplex. Okay, there is a femoral vein thrombosis. It is occlusion. Venogram showing deep vein thrombosis here and here another. Okay. What is thrombophilia? We have to screen for thrombophilia when the deep vein thrombosis is unprovoked. The patient is healthy, young age, and he has no predicting factors or no risk factors to interpret the deep vein thrombosis. So I have to suspect the familial thrombophilia. Okay, for example, they are a combination of a lot of syndromes. However, The most common are the factor V Leiden, protein C and S deficiency, and antithrombin 3 deficiency. They are the most common syndromes. They are idiopathic DVT, unprovoked, I don't know why, and less than 50 years. Okay? Family history of DVT is present usually. Okay? Thrombosis in an unusual site and recurrent DVT with no reason, unprovoked. A severe form of deep vein thrombosis when it is occluding the superficial and deep system up to the or above the groin level in the iliac veins, it will make a severe edema, what we call phlegmasia. Phlegmasia is edema in this limb. Either phlegmasia alba, whitish, or phlegmasia ceruli dolens, what we call a venous gangrene. Alba, that means the blood cannot enter the limb, and the dolens is pain, and the venous end will phlegmasia ceruli blue in color, phlegmasia alba whitish in color, and this will end by a venous gangrene. Treatment of deep vein thrombosis. The aim of treatment is to prevent pulmonary embolism by itself, and again we have to reduce morbidity and mortality from this syndrome, decrease the risk of recurrent again DVT and again, then and the incidence of post-thrombotic syndrome to be diminished. The anticoagulant therapy we start with, it is a primary medical treatment of DVT since 1930s, early. It is non-invasive, and there is a limitation in the form of intracranial hemorrhage or active bleeding or active peptic ulcer, for example, thrombocytopenia, because it is lowering the platelet again, and the patient will be at risk of bleeding. With recent major surgeries, they are contraindication to use the anticoagulation. For example, the unfractionated or the gold standard heparin, okay, the low molecular weight, this is the fractionated heparin, okay, we take a part which is responsible for the anticoagulation, so there is low side effects and more tolerated anticoagulation. For example, the enoxaparin, the Clexane, for example. Factor 10 inhibitor, like the oral rivaroxaban, new oral anticoagulant, or the Xarelto, it is a new oral anticoagulant. Fontabarinox or Arixtra, it is a parenteral subcutaneous, okay, or Abixaban, Eliquis, it is again a new oral anticoagulant. So all these acting by factor 10 inhibitor. The coming one is the direct thrombin inhibitor, like the dabigatran or pradaxa. It is again an new oral anticoagulant. And the most common and old one with many complications or side effects is the vitamin K antagonist, which we know as warfarin or Coumadin. Rapidly, we have to remember by the clotting cascade, either extrinsic pathway or intrinsic factors, all are collecting in factor 10 and factor 10A, then transforming prothrombin to active thrombin form, which will transform the fibrinogen to fibrin. So this cascade could be stopped by in the collecting two ways, either factor 10 or the thrombin. The unfractionated or the conventional heparin, it is used intravenous or subcutaneous, but could not be given oral. So heparin prevents extension of the clot and decrease the incidence of pulmonary and recurrent thrombosis. It will interact with antithrombin 3, so it's body primary anticoagulant to inhibit thrombin. Inpatient setting, rapid onset, treatment of choice for end-stage renal disease because it has minimal effect on the kidney, and monitor with activated partial thromboplastin time. It is all the standard is the low molecular weight appears. The low molecular weight, as I said, given daily subcutaneous, replaces the intravenous heparin. Enoxaparin or Lovenox and deltaparin, they are the examples. Those based on body weight and renal function. Usually we are not using a routine tab. No laboratory test, for example, partial thromboplastin time. Used in outpatient setting, could be domiciliary at home. The low molecular weight used to treat deep vein thrombosis in patients with malignancy. It is the gold standard in malignant patients associated with deep vein thrombosis, the low molecular weight heparin, and again in recurrent deep vein thrombosis. Factor 10A inhibitors, like the rivaroxaban, blocks the factor 10A, which is responsible for the thrombin, as I said, from the cascades. First oral medication in this class, new oral anticoagulant, start by 50 milligram twice daily for 3 weeks, and then continue for 20 milligram once daily till around 6 months, until proved by the duplex there is recanalization and no deviant thrombosis. Should be avoided in patients with creatinine clearance less than 30, no routine lab or no antidote. The antidote, actually there is an antidote, but it is very expensive till now. The heparin, the antidote is protamine sulfate. The warfarin, the antidote is vitamin K, to remember. Again, another example is the parenteral vontabrinars. It is given as subcutaneous once daily, indicated in prevention of deviant thrombosis post-orthopedic surgery, daily dose only, once daily, and use in conjunction with end-stage renal patient if creatinine less than 30. No lab parameters and no antidotes. Anticoagulants has no antidote. We can overcome this condition if in emergency by giving the patient a fresh frozen plasma to give the patient the coagulant factors in case of reversing the effect of this, but per se an antidote has no antidote. Again, an example of factor 10A inhibitors, like the new oral anticoagulant apixaban, Eliquis, recently indicated in prevention of deviant thrombosis post-operative in hip and knee replacement. Again, its dose is 2.5 milligram twice daily, and not currently approved for treatment of DVT. This is an old statement. It is actually nowadays it is proved in treatment of DVT, because we have another dose doubled, 5 milligram. So in active DVT, we're giving the patient 5 milligram, not 2.5 milligram. Direct thrombin inhibitor, another class of anticoagulant, okay, like the dabigatran, Pradaxa. It is approved for treatment of DVT, but must have received 5 to 10 days of intravenous. It should be proceeded by anticoagulant parenteral, because it has several days to be activated. If creatinine clearance more than 30 or 150 milligram the dose, or if creatinine clearance is well or affected kidney, I will reduce the dose to 75 milligram twice daily. Shown to be non-inferior to warfarin, and no lab monitoring or no antidotes. Vitamin K antagonists like the warfarin known Coumadin interrupt the production of vitamin K, coagulation factor produced by liver, and the effect usually within 72 hours and not immediately. And the INR, international normalization ratio, should be doubled but not exceeding the triple to be as effective as anticoagulant. It has low cost, and the vitamin K is the antidote, and however there is side effects that controlling of INR could be difficulty. There is resistance to warfarin, and again it is affected by many drugs and diets. Complication of anticoagulant in general, all anticoagulants. Sure, hemorrhage is the first complications. There is a high risk of major bleeding. Bleeding risk increase over time of therapy. Okay, and the kidney affection again in chronic kidney diseases. Treatment of hemorrhage in intravenous, there is an emergency, so I have to stop the drug and given fresh frozen plasma or platelet substitute. If severe hemorrhage, protamine sulfate. So these are the ways to overcome the bleeding. In case of low molecular weight heparin, okay, protamine sulfate has a low functioning but still have. So I have to give protamine in cases of hemorrhage in low molecular weight heparin. In case of warfarin, I have to stop the drug, giving the patient vitamin K and fresh frozen plasma. The duration of anticoagulant, it is a matter of debate. Okay, first DVT from 3 to 6 months. However, we can judge this by repeated duplex, that there is a resolution or recanalization of the deviant thrombosis. Question to be answered: in case of malignancy, okay, I can give the patient at least 6 months or lifelong even, because there is a possibility of associated deep vein thrombosis or venous thromboembolism in malignant patients. When there is provoked cause of deep vein thrombosis, so no need to maintain the long life anticoagulant. But it is if it is unprovoked, okay? If it is unprovoked and proved by the hypercoagulable state, I may maintain for life. However, if it is provoked, just till the condition is ended, I will end the anticoagulant. For example, in pregnancy, postoperative immobility, till the patient regain the normal or the normal mobility and life, I can stop the anticoagulant. Recurrent DVT, at least 1 year, possible lifelong. If I don't know what it is, or he has thrombophilia, or he has a cancer, so I might maintain for lifelong. Numerous recurrent DVT, lifelong, despite of circumstances, it is ended, خلاص, يعني it is repeated, so what will I stay for? Location of DVT. At the proximal DVT, the higher or the longer duration of anticoagulant than the tibial, for example, duration. Cuff veins, proximal veins. This is a percentage. When post-phlebitic syndrome secondary changes due to deep vein thrombosis are presented usually in higher levels, like the external iliac, common femoral, and deep femoral. They are involving in 70 to 80% of the DVT. However, in tibial veins below the knee, 20 to 30% of DVT, and they mostly has low effect as post-phlebitic, but might happen, but has low effect as post-phlebitic, chronic post-phlebitic syndrome. So the anticoagulant in calf veins DVT, if it is symptomatic, it might maintain for only 3 months. If it is asymptomatic, we might not treat it or prophylactically covered by anticoagulation to avoid extension of this tibial deep vein thrombosis to a major like the popliteal or femoral veins. Thrombolysis. Thrombolysis is another way to dissolve the clot. But we prefer in venous disorders to direct this thrombolysis due to severe side effects up to intracranial hemorrhage to be directed toward the thrombus by catheter-directed thrombolysis. The catheter is introduced within the clot. It has side perforators, rents, and I will introduce the thrombolysis and close proximally and distally to avoid escape of this thrombolysis in the general circulation. It will act only inside the clot itself. So it is integrated for proximal DVT to avoid phlegmasia alba or phlegmasia dolens or to avoid the post-phlebitic syndrome. It is indicated in phlegmasia, chronic limb ischemia, again to avoid amputation from phlegmasia. Patient with low bleeding risk, I can give them thrombolysis and should be within the first 72 hours. Up to 14 days, I can give in coaches, but the best time is within the first 72 hours. This is contraindicated in patient who is active bleeding, and the disadvantage, as I said, long infusion time, and the produce is costly. Mechanical embolectomy. I will introduce a rotator to cut or fragment the clot, and by suction or ultrasound suction, I will absorb this clot to avoid embolization in another system. So it is a popular adjunct to the thrombolysis, should be combined with thrombolysis or anticoagulant to remove or reduce the thrombus burden, and the time of thrombolytic infusion and the hospital stay should be diminished. In an example, okay, fluid with rotatory, and absorption of the clot by the system. The inferior vena cava filter, IVC filter, I could insert it in patient with symptomatic pulmonary embolism or contraindications to anticoagulation. These are the two indications of inferior vena cava: either proved pulmonary embolism, showers, or patient has deep vein thrombosis. I cannot anticoagulate the patient. For example, he is have active surgery, will be operated, or he has bleeding site, open wound, for example, or active peptic ulcer, any reason, I cannot give the patient anticoagulation in a patient with deep vein thrombosis to avoid pulmonary embolism. It is an indication of pulmonary or by inferior vena cava filter insertion. So IVC filter, it might be temporary or maintained, either retrievable, I can remove it within first month or 6 weeks, I can remove it, so I put it momentary for a while, or not retrievable, I could not be removed, so it will be inside for the life of the patient. It's in the shape of the filter, make like an umbrella to avoid escape of the clots from the lower limb to the pulmonary artery. This is a feature venogram to show how it is inserted. Why we have to treat the deep vein thrombosis? Because it reduces what I said, the post-thrombotic syndrome. As I said in my colleague Dr. Naguib, the changes, what are the changes of venous hypertension are excessive and rapidly and obviously in patients with deep vein thrombosis, because it is a secondary coronary vein insufficiency, what we call, okay? So post-thrombotic disease is proved post-deep vein thrombosis, and logically, when the vein is large, will affected by more severe post-phlebitic. For example, valves are dysfunctional to reduce thrombus, and blood moves both direction in compton valves. This will lead to venous hypertension and will make many changes, what we call venous post-thrombotic syndrome or secondary venous post-thrombotic syndrome. So the rules for treatment, this is the features of post-thrombotic fibrosis with minimal cellulitis of the skin and scales, itchy, ulcerations, and pigmentations. These are the changes. So the goals of DVT treatment is to avoid the post-thrombotic syndrome, which is present in 50% of proximal deep vein thrombosis within the first 2 years. So the proximal, that means the femoral or iliac deep vein thrombosis. So more than half of the patient will suffer from post-phlebitic syndrome if they are not well treated from deep vein thrombosis. So the post-thrombotic syndrome, as I said, ulceration seen in post-thrombotic syndrome could be treated by various wound products, compression, leg elevation, skin grafting, hyperbaric oxygen, and by compression stocking, okay, graduated elastic stocking. Increase the deep vein flow by creating pressure on superficial veins and reduce the post-thrombotic manifestations. The compression stocking, the higher pressure is 30 to 40 millimeter mercury, so it will not exceed the diastole, so it will not occlude the arterial flow. It only emptying the superficial venous from its presence inside the veins. So it will not avoid the arterial flow toward the leg because they are lower than diastole of the arteries. Again, we can put them on empty leg, so it is better to elevate the leg for half an hour at least before wearing the elastic stocking, and elastic stocking is worn during the daytime hours. We have the below knee, above knee, or whole limb elastic stocking. Long-term consideration to remove what we call the retrievable inferior vena cava. Usually we can first to be removed within the first 6 weeks. More than that will form an adhesion and fibrosis. It will be difficult. With a snare to start the hook, okay, the hook via a catheter will placate the inferior vena cava filter and enter it within the catheter to be removed. This is the inferior vena cava within the catheter to be removed. In the hospital, prophylaxis. This will be controlled by Wells criteria. I said in the first few slides, Wells criteria. So if the patient is moderate or high risk, I have to start mechanical in the hospital by pneumatic compression boots. And pharmacological, by low molecular weight, fondaparinux, unfractionated heparin, or even by warfarin. I have to maintain the patient anticoagulating well during this period, okay? The pneumatic compression, what is mechanical, I can aid or add elastic stocking intraoperative. But the pneumatic compression is the best and classical way to be during surgery and postoperative period. Thank you very much. Thanks, man.